So far, we've considered immune diseases that center around foreign antigens. Now let's consider what happens when an individual develops hypersensitivity to himself or herself. Autoimmune diseases are where antibodies and even T cells launch an abnormal attack against self-antigens. In general, they're either systemic or organ-specific, and there are more than 80 recognized autoimmune diseases. The systemic response will involve several major organs, whereas organ-specific responses revolve around only one organ or tissue. The causes of most autoimmune diseases are still elusive, but we do know that susceptibility in general is genetically linked and also influenced by gender, with females having the most susceptibility, except in the condition of ankylosing spondylitis, which is where the immune system causes fusion of some of the spinal bones as well as the sacrum. There are particular genes in the class 1 and 2 MHC labels that coincide with certain immune diseases. Here's a couple of examples. HLA types, and HLAs are a type of MHC protein. There's HLA type B27. This one's associated with rheumatoid arthritis and ankylosing spondylitis, whereas HLA B8 is associated with Graves' disease and myasthenia gravis. So individuals possessing these specific HLA types are more likely to come up with these associated autoimmune diseases. The interesting thing here is that even most healthy individuals have low levels of autoantibodies. Thus, we suspect that they have some kind of specific function of benefit. Most likely, it's for the disposal of old cells and cellular debris, but the recognition system somehow gets broken. Here are some of the theories of why autoimmune diseases come about. There's the sequestered antigen theory. Now, some tissues are hidden from the immune system during fetal development. For example, the central nervous system is behind the meninges of the brain. The lens is tightly locked up inside the eye. The thyroid gland and the testes both are isolated from regular circulation until there's some sort of infection or trauma or deterioration of that tissue, at which point the antigens on these tissues are released out into the circulatory system and the immune system will respond to them. There's the clonal selection theory. You will recall that clonal selection is how we select B lymphocytes or T lymphocytes that are specific to certain antigens, yet not to self. Perhaps some self-reacting lymphocyte clones actually remain in circulation. These are known as forbidden clones, and at some point they recognize an antigen that's self and end up eliciting an autoimmune response. There could also be inappropriate expression of MHC2 markers. This is called the bystander effect. It's where T cell activation inappropriately turns on B cells that can react with self-antigens. Now, we need some to react with self-antigens, again, in order to do that cleanup function. But when they're inappropriately turned on, the B cells are going to attack self inappropriately. Also, there's an idea of molecular mimicry. Some microbial antigens are very similar or mimic the surface markers of our own cells. A great example of this is proposed with psoriasis and its association with the Streptococcus bacteria. Individuals that have psoriasis often have flare-ups of the psoriasis following a streptococcal throat infection. So there's a potential that their psoriasis developed because of this antigen mimicking capacity of the Streptococcus bacteria. Viruses also can alter cell receptors. So some previous viral infection may cause the alteration of cell receptors that causes an immune cell attack on self. Diabetes type 1 is an example of this sort of autoimmune disease. Another proposed idea is there are autoimmune regulatory proteins, otherwise known as AIR proteins. The purpose of these proteins is to direct expression of genes that tell the immune system not to respond to cells. And recently, scientists have noted that many autoimmune disease patients have defective air proteins. Let's consider a few cases now of a variety of different autoimmunities. First of all, systemic autoimmunity, such as lupus or rheumatoid arthritis. Lupus causes a characteristic butterfly-shaped rash across the nose and cheeks that you can see in the picture to the right, and results from autoantibodies attacking a variety of different organs. So there's very broad systemic effects. Rheumatoid arthritis is a progressive, debilitating damage to the joints. It's caused by autoantibodies from the immune complexes that bind to synovial membranes. They activate the phagocytes that then release cytokines and cause great inflammation. This chronic inflammation leads to scar tissue formation and then joint destruction. There are a couple of autoimmunities of endocrine glands, like Graves' disease and diabetes mellitus. Graves' disease affects the thyroid gland and results from attachment of autoantibodies to receptors in the follicle cells that secrete thyroxine, and thus cause an overproduction of thyroxine and thus elevate metabolism. In diabetes mellitus, we're dealing with the beta cells in the pancreas. These cells usually secrete insulin that's involved in regulation of blood sugar. They're attacked by sensitized cytotoxic T cells, and so they break down and gradually lose their capacity to secrete insulin. There's a number of novel treatments involved using stem cells for diabetes type 1. There are also neuromuscular autoimmunities like myasthenia gravis or multiple sclerosis. Myasthenia gravis is primarily characterized by a pronounced muscle weakness. Usually it's felt first in the eyes and the throat because these are very tiny skeletal muscles. It results from autoantibodies attaching to acetylcholine receptors. Acetylcholine receptors are then blocked, and thus transmission of acetylcholine is blocked. This causes paralysis in the muscles. Multiple sclerosis is a similar case in which we have lesions of the myelin covering the neurons in central nervous system. This reduces signal transmission, and thus we see muscular weakness and tremors. Often there are difficulties in vision and speech also, and it can also result in paralysis of muscles. It's mediated by both T cells and autoantibodies. So those are just a few examples of different autoimmune disorders that we've touched on throughout this chapter. When you consider all the details of immune function, it's really quite amazing that the whole thing works. But on occasion, an individual is born with, or an individual develops over a lifetime, a weakened immune response. This causes recurrent, overwhelming infections, often from opportunistic microbes. There are two general types of immunodeficiency diseases. These are hyposensitivities, so less sensitivity in the immune system. There are primary diseases, which are present at birth, or they're congenital immunodeficiency diseases, and they usually stem from genetic errors. And then secondary diseases are acquired after birth, and they're either caused by natural or artificial agents. In the table below, you can see some general categories of immunodeficiency diseases with some of the selected examples. Let's take a look at some of the more common primary immunodeficiency diseases. These diseases affect both specific immunities, involving antibody production, and less specific ones, like phagocytosis. The figure shows the places along the path of lymphocyte development that defects can occur. Here we have the development of B cells. We'll cover some of those deficiencies, and then the development of T cells. Because of the divergence of B and T lymphocyte development, individuals could have deficiencies in either one or both of these lines. But naturally, you know the interaction between T cells and B cells, so some deficiencies can really affect others. For example, if the helper T cells don't work properly, then inevitably that's going to affect the B cell activity. Most of these are due to inherited abnormalities, but often the exact nature of immunodeficiency isn't even understood. As you can see, there are various places along the way that things can run into trouble, which will end up in us having opportunistic infections able to take over. So we'll begin by looking at clinical deficiencies in B cell development or expression. Many of these are X-linked recessive traits, so that explains why they appear primarily in males. They usually appear as an abnormality in immunoglobulin expression. Agammaglobulinemia is the absence of gamma globulins entirely. That means there are absolutely no immunoglobulins, no IgA, no IgE, so on and so forth. It's very rare. Most doctors prefer to use the term hypogammaglobulinemia because there are some gamma globulins present in most cases. The symptoms naturally involve recurrent serious bacterial infections. They're relatively common, and the treatment is going to involve passive immunotherapy with immune serum globulins, as well as continuous administration of antibiotics. So here we are in the B cell line. Congenital agammaglobulinemia would result from no B cells being able to go into the bone marrow for maturation, and so we get no mature B cell lines. However, hypogammaglobulinemia, try saying that one, will result in immunoglobulins not being made properly, and so we'll have none of these antibodies produced to launch the appropriate attack. As I said, very uncommon to have absolutely no gamma globulins or IGs. IgA deficiency is the most prevalent hypogammaglobulinemia condition. In fact, about 1 in 600 individuals have this condition. That means they have normal B cell development, but they're unable to synthesize IgA. And if you think back to what IgA does, it's involved in mucous membrane protection. So individuals that have the IgA deficiency have constant mucous membrane infections, so respiratory infections, GI infections. In these individuals, the T cell function is usually pretty normal, and an individual will show up with the symptoms beginning about 6 months after birth. Often they suffer from a wasting syndrome and a consequent reduced lifespan. With passive immunotherapy, individuals can be treated with these immune serum globulins that contain the immunoglobulin that they're missing in order to help them fight infections. We'll look at some deficiencies in T cell development or expression. T cells have a critical role in immune defenses, so genetic defects often result in broad spectrum disease. It can be much more serious than defects in the B cells. You'll recall T helper cells are required to assist most other specific immune responses, so without them, there's going to be problems in both lines of defense. So as with B cells, T cell issues can occur anywhere along the development spectrum of the T cell line. We can have some types of immunodeficiency shut down the immune system right away. DiGeorge Syndrome involves shutting down production before the thymus. And then adenosine deaminase deficiency prevents us from doing full-on cell-mediated immunity. The most severe of these involve congenital absence or immaturity of the thymus gland. This is what happens in DiGeorge syndrome. The thymus gland doesn't develop some of the lobes that it needs, and so there's not the space for development of T cells that are necessary to develop a proper immune response. In DiGeorge syndrome, we have this defect in the thymus that happens during embryonic development so that certain lobes don't develop. Some of these conditions are associated with chromosome 22 deletion. So T cells, because they don't have a thymus to mature in, don't mature properly, and so we lack proper cell-mediated immunity. The cellular defenses are thus diminished, which leaves the individual highly susceptible to viral, protozoan, and fungal infections. Often the symptoms display themselves much as the individual shown on the right. Of course, having no T cell maturity means that vaccinations pose a pretty serious threat, especially if they're based on attenuated cells. One of the only ways to effectively treat DiGeorge syndrome is by transplantation of thymus tissue. So we could have B cell deficiencies, T cell deficiencies, or combined immunodeficiencies where we have dysfunction in both the B and T cells. This manifests within days after birth. It's a hugely debilitating condition. SCIDs, or severe combined immunodeficiencies, are potentially lethal. Some are due to complete absence of lymphocyte stem cells in the marrow. And you can see if this happens, then no further development of either B cell or T cell lines can occur, which essentially leaves the individual without an immune system at all. Others are due to dysfunction of B cells and T cells later in development. The most common forms are Swiss type agammaglobulinemia and thymic alphoplasia. In these conditions, the lymphocyte count is extremely low and the blood antibody content is greatly diminished. That leaves the individual with very poorly developed cell-mediated immunity. In rarer cases, we have things like adenosine deaminase or ADA deficiency and Bare lymphocyte syndrome. ADA deficiency means that the individual has no adenosine deaminase. This is an enzyme that's important in breakdown of metabolic products. So it lends itself to a buildup in the metabolic product adenosine, which destroys the lymphocytes and renders them inactive. In Bare lymphocyte, the individual actually lacks genes that code for class 2 MHC proteins. Without class 2 MHC proteins, there's no antigen presentation. So again, you can see how this would have a very broad spectrum effect on the immune system. Just the basic existence of these individuals require rigorous aseptic techniques. You're probably familiar with the boy in the bubble situation, where he literally has to live inside a plastic bubble because he has no lymphocytes, no B cells, no T cells, which means no immune system. So any extracellular pathogens will grow unchecked and lead imminently to death. This can be treated only by total replacement of lymphoid cells. This means a bone marrow transplant. But in this situation, because the individual has no immune system himself, then it leads to graft versus host disease. So the transplanted bone marrow actually invades the host immune system with the immune cells that are within it. There are some gene therapy trials going on. These actually replace the defective genes. Once the defective genes are replaced, then the individual, in theory, can produce their own stem cells again. Thus, they can be relieved of SCID. There are some troubles in these clinical trials, but they're showing up to be more successful than most other gene therapy trials. So there are also some secondary immunodeficiency diseases. Again, these are ones that individuals develop during a lifetime. Most are caused by infection, organ disease, chemotherapy, or radiation. AIDS is an example of secondary immunodeficiency disease. There are several types of immune cells, including helper T cells, monocytes, macrophages, and the antigen-presenting cells that become infected by the HIV virus, which makes them very ineffective at their job. The depletion of the helper T cells means that the immune response is not what it should be. This allows cancers and opportunistic protozoan, fungal, and viral infections to grow relatively unchecked. So individuals die of cancers and infections that their immune system would normally have fought off. Other secondary immune deficiency diseases can be brought about through cancers that target bone marrow or lymphoid tissue. Naturally, if we're destroying these tissues, we'll see that there can be malfunctioning of either B cell or T cell or both lines of immunity. So that brings us to the end of this chapter. Before we move on, let's have a quick concept check. Which of these is the boy in the bubble disease? Is it AIDS, DiGeorge Syndrome, SCID, or agammaglobulinemia? Well, we know that AIDS isn't about a boy in the bubble. DiGeorge Syndrome is all about T cell deficiencies. And then combined is where we have SCID. So severe combined immunodeficiency would require the boy to live in the bubble. So we can take agamma globulinemia off the list also.